Welcome everyone to the third live public Q&A organized by Tinnitus Quest. Tinnitus Quest is a new nonprofit dedicated purely to silencing tinnitus, and we're organizing these Q&As with tinnitus researchers to give you guys a chance to engage with them directly, and really it's in the spirit of openness and transparency, which is part of what we want to accomplish as Tinnitus Quest. We want to involve patients in the quest for a cure and be transparent about the research that's going on. All right. So Dirk de Ridder is definitely one of the most famous and most published tinnitus researchers in the world. He's actually a neurosurgeon by trade. He's a professor in the University of Otago, New Zealand. He has his own clinic in Belgium. And today you have a chance to ask him questions directly. I see that some people are asking questions in the chat. Please put all your questions in the Q&A box. Otherwise, they will not be asked. And we have so many questions that really it will be impossible to get to all of them. We're really going to do our best today. I don't know, Dirk, if you're able to stay a bit longer than to the hour. All right. Perfect. Right. So we're just going to dive right in, Dirk, and I'm just going to try and get through as many of these questions as we can and try and keep it a little bit structured if possible with this this big load of questions we've got here. So this is a very general one, but I think it's a nice one to kick off with. How do I determine the cause of my tinnitus?
Well, that is, of course, a very nice and a very important question because there's multiple causes for tinnitus, but there is basically two different mechanisms that we know exists. If you can, just like in the somatosensory system, what we perceive is determined by the input, so what comes from the outside, and by suppression, what is suppressed by our brain. So for example, even though our clothes are constantly generating a stimulus in our skin, we don't feel them anymore because our brain actively suppresses the stimulus. And in the auditory system, it's the same. So you can basically have a problem with hearing loss, which you can measure with an audiometry, at least for some cases. But you can have a perfect normal hearing where sound is not suppressed. So that would be the same as constantly feeling your clothes, for example. So these two mechanisms are important to understand the answer to the question. And if, for example, you went to a concert and you have a transient or a temporary hearing loss, let's say between 4,000 or 6,000 hertz, then your tinnitus, if it's matched using a tinnitus matching test, then that should match the dip you have on audiometry. And if that's the case, then you know that the cause is the hearing loss. Now, some people do not have a hearing loss, and then the mechanism is more likely related to the fact that you have a lack of suppression. So if the tinnitus does not match the hearing loss, or if there is no hearing loss, then the most likely mechanism is a lack of suppression. And the suppression is actually generated by a part of the brain that we call the pre-general anterior cingulate. It's right in the front part of your brain, and this is typically suppressed when we are in stress. So when we are in stress, everything in the outside world might be potentially important to solve the stress, and therefore our brain will actively suppress its own brake. But if that lasts for a while, a couple of days or weeks, then the brake actually becomes atrophic, just like a muscle that you don't use anymore. And this braking part of the brain, when it becomes dysfunctional, will then also not suppress internally generated sounds anymore, and you might get tinnitus. So In this way, stress can generate or at least be part of the mechanisms that are involved in the generation of tinnitus, not by creating a hearing problem, but by creating a problem of not suppressing sound that is generated by our brain. So these are the two main mechanisms. So either it fits the hearing loss fits the tinnitus pitch, or there is a lack of suppression, usually caused by chronic, not by acute, but by chronic stress.
So if I'm paraphrasing here, I think you have a mechanism that comes from, the what they call the periphery. So it could be the ear, or sometimes it's something else like the neck or whatever it is. That's like a bottom-up signal. There's noise in the system. And then there's the top-down, which is like the higher brain functions that would normally like suppress that. Somehow that mechanism is not functioning.
Yes, that's correct. So either a bottom-up or a top-down deficiency in the auditory system.
And would that is that the same for everyone, or is it sometimes more the bottom-up or more the top-down, or do we know about that?
Oh, it can be only one of the two. For many patients, it's a combination, but you can have a hearing loss, like if you go hunting and you have a noise trauma, or if there is a physical trauma to the ear, and then it does not have to be associated with a bottom-down, with a top-down suppression deficit. In others, there might not be any hearing loss, and it might be purely top-down. So yes, in many patients it's a combination, but it can be either of the three mechanisms: purely bottom-up, purely top-down, or a combination of the two.
Got it. So we got a lot of questions in this vein. I'm putting one of them up now, but basically a lot of people are asking about fluctuations in their tinnitus and where that comes from.
Yeah. So fluctuations means that the tinnitus is constantly there, but it can be worse or less depending on the moment. Now, the most common and the best known mechanism is stress, of course, but it does not have to be stress. We know that sleep is also very important. So if you have a lack of especially deep sleep or REM sleep, that can cause fluctuations on the next day. So some people, when they wake up in the morning, will say, I can tell in the morning whether I'll have a good or a bad day, but also the fluctuations can be determined by how well you slept during the day before. And this has been investigated by Winnie Schlee's group, who's now in Switzerland. And what they found is by using momentary assessment. So people were asked via an app to score their tinnitus, and then these data were kept for a couple of days. It was actually shown that what happens the day before can determine whether you have fluctuations on the day after. So other causes for fluctuations might be just the amount of surround noise, or the opposite, silence. So there is external immediate causes of fluctuations. There might be stress that causes fluctuations, but they tend to be a little bit longer. And there might be problems with sleep, or even what happened the day before, that can cause the fluctuations of the following day. Yes, and this has been looked at by a French researcher, and he could not really find the exact cause of it, but it really depends usually on. So when you go, sleep has different stages. It goes from stage 1, which is very being a little bit drowsy, to stage 2, where you're nicely asleep, and then stage 3 is when you're deeply asleep. Now, if you wake up from stage 3, you go back to 2, 1 to REM sleep, which you usually don't get if you take a short nap. But If you wake up from very deep sleep, what you then need is that your sympathetic system kicks in to make you awake. And now your sympathetic system is what people also call the fight and flight response, which is also the same as a stress response. And so when you wake up from deep sleep, your fight and flight response will be at maximum just to wake you up, and that can then cause the peak in the tinnitus loudness, just by the same mechanism that I've mentioned before, by a lack of suppression, because the brain assumes that everything that is associated with a fight and flight response is very important, and therefore it will push us to the forefront of consciousness rather than having it slimmer somewhere in the back. So it's probably the depth of the sleep where you wake up from that might determine the amount of stress response from your body that then determines the fluctuations. Yes, that is something that has not been really studied a lot, the mechanism of reactive tinnitus. So um, if the tinnitus can be seen as from a Bayesian brain mechanism. What that means is the brain normally functions to predict the next upcoming events. And this is for a very practical point of view. If you, it takes about 300 milliseconds, so almost half a second, to become consciously aware of something. So in reality, we live about half a second behind on what is really happening in the environment. So the only way to live really in the moment that we are is by predicting what's going to come, and therefore be able to respond to the things that happen now, because otherwise you're always running behind. Now, so tinnitus from this theoretical perspective has been described as when your brain makes a prediction, then it senses what it predicts through its different senses, your vision, your hearing, your smell, etc. Now, if you have, for example, hearing loss, then the brain can't sense whether its prediction is right or wrong. And then depending on how you feel, but if then the brain says, well, I'll better be safe than sorry, so it might generate the sound that it expects to be there. And this is what you have as tinnitus. Now, if you take it one step further, then the reactive tinnitus is where your brain really says, well, if I hear something in the background, then the problem is it makes it even more difficult to verify whether these predictions are right or wrong. So I'll make sure that it's even more. It could be potentially dangerous. So I will generate it even louder, just to be safe, on the safe side. Now this is problematic, but it's a normal physiological Bayesian mechanism to try and make sense of the outside world. And our visual system works as such, our auditory system. And normally what we do is the brain says, I will use all sensory information that I can get, which we would say, if it looks like a duck, if it quacks like a duck, if it flies like a duck, it's most likely going to be a duck. So what our brain does is it will try to pick up auditory information, but you will also automatically lip read to see whether what you hear is really coming from the person that is standing in front of you and not from somebody else in the neighborhood. And if this mechanism only focuses on the sound, then the reactive tinnitus might be more sensitive or more predominant than if not. But again, these are physiological hypotheses that still need to be tested. Yeah. Yeah. So, well, we had a very small group of 9 people who had tinnitus or zero tinnitus. So some days they had tinnitus, some days they had zero tinnitus, which is, of course, good because the way we usually work in science is if we compare groups of people without to groups of people who do not have tinnitus. But here you can compare people who once in a while have tinnitus to once in a while have zero tinnitus and see what is different by doing EEG scans, but you could also do fMRI, any kind of brain imaging. And then you can look at what do they have in common and what is the difference in the states of tinnitus and no tinnitus. And what we found is that this area that I was talking about before, the pre-general to rostral anterior cingulate cortex, so that breaking part of the brain was non-functional on the days they had tinnitus and was functional on the days they had no tinnitus. So it seems, and this theory goes back to Rauschecker's work more than 10 years ago, where he found an area a little bit more closer to the base of the skull, where he found that if that area is somewhat atrophic, like what you would see in people who are chronically stressed, that if that doesn't work, that then those people would have or would be more likely to have tinnitus than without. Now, what is new about this small paper that we published is that the people were their own controls. So we could not say, well, there might be other differences. It was the same people on different days. And so the braking mechanism seems to be very, very important in whether or not you feel tinnitus, just like whether or not you feel your clothes.
The questions on the screen. So there were also a lot of questions around. Okay, I'm hearing that I'm still not heard. I don't know what to do about that. You can hear me now? Oh, sorry, I'm messaging with Marco. Yeah, okay. It seems people can now hear me. Good. Sorry for the interruption. So just need a moment to find my thread again. Yeah, I was gonna ask about somatic tinnitus because we did get a lot of questions, so I'm just putting one of them up here. Is that something that you've looked into, and how does this relate to your model with the bottom up and the top down and everything?
Yes, so it combines what I've been mentioning before. So the question, why does it seem that physical acts like opening your mouth widely, earlobe massage, breathing exercises work to stop tinnitus temporarily? Well, there's already in this question multiple actions, but so basically the main question is, how does the somatosensory system, how is it possible that it can modify tinnitus? The mechanism is relatively simple from an anatomical point of view. From an anatomical point of view, there is connections between the C2 nerve, so the nerve that supplies the back of your head, and your trigeminal nerve that supplies the front of your head, so your face, etc., and the auditory pathway at multiple levels of the auditory pathway. So going all the way to the place where the auditory nerve gets into the brainstem, all the way to even the cortex. So at every step there is a somatosensory, but also visual, even vestibular input into the auditory system. This has multiple reasons. One is what I mentioned before, is to be able to go and use this multisensory coherence. So if it looks like a duck, if it quacks like a duck, if it flies like a duck, it's most likely going to be a duck. So basically, the brain wants to verify whether what it hears is really there or not by using the other senses. That's one mechanism. Other mechanism is to drive the appropriate response. So for example, in cats, the the C2 nerve is the nerve that brings the information from the ears to the ear, so that the ears can move towards where the sound comes from, and therefore it can localize the sound better. So this is an interaction between the somatosensory system that gives information about the proprioception, so that the brain of the cat knows, well, my ears are now in this position, so if I hear a sound better, depending on how I move my ears, I can localize it better. So there's multiple reasons why these interactions do exist. Most of the time, the interactions are excitatory, which is normal, so that if there is, so that you can drive the system. But of course, if you develop tinnitus, then in more than 70%, 70 to 80% of the people, that tinnitus can be modified by having influences from the somatosensory system that will then go through at all the levels of the auditory pathway to modify the auditory inputs. So it's actually surprising that some people do not have it. You would expect that 100% of the people have it, rather than 70 to 80%.
Yeah. I actually don't have any somatic influence to my tinnitus, so I'm an outlier then. This question, maybe it's a bit related to the reactive tinnitus one. I'm not sure if that's something different, but some people experience this kind of distortion of sound. Is that related to tinnitus actually, or is it something entirely different?
It's not something, you see it once in a while, but it's relatively rare. Now, when sounds are distorted, that means that the brain cannot filter the input correctly to know what it really is. So if you and you can do this artificially by if you make a video of my mouth going up, opening and closing, and I will say the word ba, for example, but you at the same time you present ba, then the patient might hear da. So then this distortion is caused by the interaction of the visual system and the auditory system. So if this interaction between the senses are not finely tuned, then the brain gets somewhat confused, and it will generate something in between, which usually causes a distortion. So it is the problem is again this multisensory interaction, and that is usually coming from a central top-down problem.
So to everyone who's listening, and I'm assuming you can now hear me, we'll get to all the questions about treatments. I'm kind of saving those for the second half, and for now focusing more on the symptoms and mechanisms, but we will definitely get there. So various questions came up around tinnitus and dementia, perhaps because this is also something you've mentioned or talked about, amongst others, in the Tinnitus Quest Meet the Researchers video. People ask about causal relationship both ways, right? Can one cause the other? Can the other cause one, etc.?
Yeah. So it's a difficult question to answer. You also have to see that not only tinnitus is associated with dementia. Chronic pain is associated with dementia. Cataract is associated with dementia. Hearing loss is associated with dementia. So whenever there is a lack of input in one sensory canal, whether it's the auditory, the somatosensory, or the visual, it seems to be linked to dementia. Now, this can have two very different mechanisms of action. So let's go to the first one, which is, again, this Bayesian approach where the brain makes predictions about what it's going to encounter. Now, in order to make predictions, you have to have a model of yourself in the world in your brain. So your brain constantly creates a model of the world to make actually better and better predictions. And this is what is updated during sleep. So during deep sleep, you store things in memory, and then during REM sleep, which is usually associated with dreams, then you replay this in very different scenarios so that what you've learned can be generalized and is not only linked to what you've just learned. So the brain tries to generalize it because that saves a lot of space and a lot of energy. So from this Bayesian point of view, of course, if you have hearing loss or visual loss or somatosensory loss, it's more difficult for the brain to update its model of the world, and you will be stuck with an outdated, non-appropriate model of the world, and that can then lead to dementia. So it's a normal physiological consequence of not being able to update your model that then creates the predictions. A second reason, however, might be that for those people in whom the tinnitus is very bothersome, that can cause stress. And when you have stress, chronic stress, that consumes 30% more energy in your body. So normally, the brain uses about 25% of all the energy that's available. Our immune system uses 25% more or less. Our heart and lungs use 25%, and our intestines also 25%. Now, when your brain consumes more, it has to steal this energy somewhere. And usually where it steals it from is from your immune system, because it's more difficult to stop your heartbeat or to stop your intestines, etc. So therefore, it will steal the energy from the immune system. And when the immune system is less, which normally works at night predominantly, so that our brain can get a little bit more energy during the day and our immune system at night, if that causes insomnia or sleep problems, which are very common in tinnitus, then in the long run, that might again be problematic in creating a not very good model of the world from the Bayesian point of view. But another problem is that it will result in what is called a low-grade neuroinflammation. And a low-grade neuroinflammation, we know, is associated with Alzheimer's disease and with other dementias. So on the one hand, the problem is that your neurological system, your model of the world is dysfunctional, but also your immune system becomes dysfunctional. And the combination of the two might then lead to dementia.
Yeah, I'm just pulling up this question because you mentioned neuroinflammation. So that I know there's been in the past year or two suddenly a lot of research.
Yeah. So neuroinflammation has indeed gotten quite a bit of traction more recently, and in tinnitus field that's new, but neuroinflammation has already been looked at for a while in very similar pathologies, like in chronic pain, but also in anxiety, also in depression, also in Alzheimer's disease. Actually, in every chronic disease that has been studied that is related to the brain, neuroinflammation is involved. So what neuroinflammation does is it turns something acute into something chronic. For example, if you have acute trauma, then 80% of the people who get a trauma will not develop post-traumatic stress disorder. But in 20% it does, which are the same numbers as in tinnitus, where most people will not develop or only transient tinnitus. But if you have the bad luck that you already have some neuroinflammation, then the problem is that something which is acute, which might go away. For example, you go to a concert, you have a beep in your ear. After a couple of hours or maybe 2 to 3 days maximum, it might completely disappear. Now, if you have a neuroinflammation going on for whatever other reason, that might become a problem, because then you have more risk that the acute will become chronic, whether it's acute pain becoming chronic pain, acute tinnitus becoming chronic tinnitus, acute fear becoming anxiety, acute sadness becoming depression. So it seems to be the mechanism that unfortunately changes the the three networks in the brain that control our thoughts and emotions. There is three major networks, and they don't seem to communicate well anymore. And if they don't communicate, there is no control. And then, unfortunately, the brain, out of this kind of better safe than sorry, will say, well, I have to make sure that the person perceives my this sound, and so I will generate it. And this is the problem, and that neuroinflammation seems to be the mechanism that then unfortunately prolongs every acute symptom, not only tinnitus. Now the question is, can we do something about it? I can answer that later, Hazel, if you first want to continue with the mechanisms and symptoms.
Yeah, maybe we'll just deal with the age-old question of tinnitus versus hearing loss, meaning if we can cure hearing loss, would we cure tinnitus? And I know it popped up somewhere now, but I can't find it. But go ahead and answer that.
Yes. So the question so not everybody with hearing loss develop tinnitus, and not everybody with tinnitus has hearing loss. So there is an association, but it's not because you have hearing loss that by definition you will develop tinnitus. So why do some people develop tinnitus? Why not? Well, the problem is actually relatively simple in the sense that if the brain considers the hearing loss important, behaviorally relevant, it will say, okay, well, I don't hear these frequencies, so I should hear them, so I'll generate them, because it's better to have this information than to have no information. If the brain, however, like they say in French, is a little bit more foutiste and says, I don't care whether I get this information or not, then it will not fill it in and you won't have tinnitus. So it is and this of course is also then related to part of your personality. Like it is known that if people have, so personality is often classified using five different traits, which are called the big five. And there is only one which we know is important for tinnitus, and that's neuroticism. So if you score high on neuroticism, then unfortunately your brain tends to, by definition, make lots of things very important, and therefore you have higher chances of developing tinnitus, because your brain will say, it is important that I hear everything perfectly well, and your brain cannot ignore the irrelevant information, and unfortunately that will then give people with more characteristics or a personality with a higher form of neuroticism are more likely therefore to develop tinnitus, because the brain considers the lack of input, auditory input, important, and it will generate it.
Let's tackle one more question about mechanisms. I thought this was interesting because there's a lot of talk about, you can resolve tinnitus with neuroplasticity, but it's just this general term that's kind of thrown around. We don't really know what's meant by it. And sometimes it's interpreted as, well, if I just change my perception or think differently about my tinnitus, then, that will change my brain, and then my tinnitus will be gone, or at least it won't bother me anymore. But can you enlighten us a bit more on what do we mean by neuroplasticity and how can it help resolve tinnitus?
Yeah. So neuroplasticity actually only means that our brain can adjust its structure and function to a changing environment. So what it means is that our brain is not a hardwired computer, but that it changes constantly to actually understand the outside world better. So, and this can be looked at in different ways. So basic neuroscientists will do single cell research, and they will look at it from a synaptic level, or even looking at specific glutamate receptors, which are called NMDA receptors. And this has been correlated to making more connections. And if there is more connections, that's to get more information traffic. That's the way how basic scientists look at neuroplasticity. However, clinicians who use functional imaging like fMRI or EEG or MEG, it doesn't really matter which one, will have a different definition for neuroplasticity. we define neuroplasticity as any change in functional or effective connectivity, which are just two measures of that we can extract from functional or from brain imaging. So depending on your background, depending on which kind of scientist you are, you will call neuroplasticity something different. Now, so that's neuroplasticity. So why is neuroplasticity for a clinician related to functional and effective connectivity? So connections in your brain, but large connection, not just the tiny synapses, because there is trillions of synapses in our brain. So you can't see that on any scan. But what you can see on a scan is how the big pathways change. And so the structural connectivity, so the anatomical pathways in our brain, they change, but very slowly. The functional connectivity changes constantly, and the effective as well. So the effective connectivity is from where to where does the information flow, whereas functional connectivity is more which brain parts function together. And so the network, or let's say what we call the brain network, are different parts of the brain that all go up and down together in their activity, and therefore we call it a network. And this is in keeping with network science, which studies complex adaptive systems. Whether it's economy, an ant colony, it doesn't really matter. But what all these complex adaptive systems have in common, and the brain is one of them, is that they have all the same characteristics. Now, the characteristics, some of them are not important, but the most important characteristics that they all have in common is what's called emergence. And emergence means that if you have a network, that the network will generate something that cannot be predicted based on the building blocks. And therefore, if the network changes, which we can see with effective and functional connectivity, the symptom changes, and therefore you can go from no tinnitus to tinnitus. But the good thing about that is if we know if we can describe the tinnitus network 100% accurately in every individual, then you should be able to break the network and get rid of the tinnitus. Of course, you can then say, well, why has nobody done that before? Well, the problem is that the way science works is we take, let's say, 100 people with tinnitus, and we do an analysis of these networks. Now, what we then do is we look at what they have in common. And what they have in common, we call the tinnitus network, but this might be very different for person A and person B and person C. So if we then apply a treatment that is based on the group, on what is most common in the group, it might actually not be relevant for you, because for some people, less connections might be part of the network, and for other too much. So you actually have to even use opposite treatments to break the network and thereby to break the tinnitus. So this is something that we know, and the future will actually be to look at each person's individual tinnitus network. And that's difficult, of course, to know, except if like this small group that we had where people have sometimes no tinnitus and sometimes tinnitus, then you can say, okay, this is your network, so we should be able to break it. If you cannot modify it, or if you cannot make it quiet even with some product like Xylocaine, then that could help you to determine the network at the individual level. And this is what is now more looked at, and which is called individual or personalized medicine. But we're just at the starting point of this approach.
Yeah, so this question brought us to the treatment. So let's go there. And you're already giving us an important hint here, which is that basically any treatment needs to be personalized to the individual, right? That's your belief. Let's just start very generally. This is the question. We got like 300 different variations of this question, right? So where are we really in the path towards a cure? And by cure, of course, we mean actually silencing tinnitus.
Yes. This is, of course, $1 million question, and it depends a little bit on your personality. I'm a born optimist, so I always think that within 5 years we will have found a solution. But unfortunately, history has shown me wrong. But the essential reason why we have not found a solution is because we don't understand it well enough. I'll just give you a practical example. Up to 25 years ago, we knew nothing. So the only thing that was known is that tinnitus was linked to the ear. So it is logical, if you think that tinnitus is caused by the ear, that all the focus goes to the ear. So it was hearing aids, silencers, noisers, etc. Then Rodolfo Llenas, a neuroscientist from New York, came up with an experiment where he used a magnetoencephalography, which is just a very expensive kind of EEG system that uses magnetic waves and rather than electrical waves. And he was the first to show, look, the auditory cortex is very important in tinnitus because it functions differently. It's a lot more active. And then we focused on the auditory cortex, and we all bought transcranial magnetic stimulation devices and electrical stimulation devices, and we thought we found it. We just have to suppress this activity in the cortex, and we found a solution. But this was very naive, because actually we should, if we would have read the other literature, then we might have thought, well, maybe it's not sufficient, because for example, if somebody is in vegetative state, so they're not conscious after severe trauma, and you present the sound, the auditory cortex will light up, but they don't perceive anything. So, which should already have told us that it's certainly not the end all of everything. And then Winnie Schley came up and he said, well, no, it's not one area in the brain. It is actually a whole network that we need to address. And since then, of course, we've been looking at what is this network with its weaknesses, that we have some idea about which areas are more or less involved in many patients, but certainly not in all. And then the question is, how can we attack these networks? Because with the transcranial magnetic stimulation, for example, you only attack one area at a time, which is not enough to break an entire network. So then we had to follow and wait till better imaging technology became available. And now we can look at these networks with way more accuracy than we could when Winnie Schley did his first experiments. The problem, however, was we had no tools. We had no tools to break networks. And this is where in the last maybe 5 years only, we have now some tools that allow us to be a little bit more specific. And now we can not just treat one area, but we can start treating whole networks. So whenever there is something new is found, then there is always a delay by building new devices that can then manipulate the new thing that we found. For example, now we all think that neuroinflammation is important, but there is only one kind of scan, PET scan, that can show neuroinflammation, and this is has not yet been done in tinnitus for variable reasons. So let's assume that with this, when we start doing these PET scans, we find that there is 3 areas that are inflamed. Then we have to target those 3 areas in one or another way so we can stop the local inflammation. Now, luckily, we can do that with electricity. We can do that with magnetic waves, but also with some medication. The problem is that there is not just one kind of inflammation. There's acute inflammation, which is not important. That's the one that you have when you twist your ankle and it swells, it becomes red, it's painful. That's not the kind of inflammation I'm talking. This is about a more chronic inflammation, like you would have in mucoviscidosis or in some heart pathologies, etc. So but even within this chronic inflammation, there is different subtypes. For example, the inflammation that is used to fight a virus is different than one that's used to fight a bacteria. So we still have to then tweak which inflammation is important. And that means that we will have to do trials in which people with tinnitus will receive anti-inflammatory treatment like they would give for rheumatoid arthritis. And if that shows, okay, it can give a little bit of benefit, then there is still maybe a group of 70% of the people who are not benefited. And then we might have to see, well, what antiviral inflammatory pathology, how can we address this? So the reason why it goes slowly is because our understanding is growing, and there is always a delay between what we understand as a new mechanism and the new tools that are available to address it, getting it past ethical committees, finding support for this, finding money to do that. But the good thing is that whereas 20 years ago we had no clue at all what tinnitus was about, is that now we're progressively getting a better understanding, which makes the chances that we will find something bigger and bigger. Will that say that within 5 years we do have a solution? I hope it is, but for that we need a lot more money and a lot more research. If you look at AIDS, that was solved in a very short time period. COVID was solved in a very short time period, but there was billions of dollars being spent there. Whereas for tinnitus, unfortunately, the amount of money that is being distributed for research is very little, which also means that the scientific advances go very slow. Because if tomorrow they would say, okay, well, here is a lot of money, well, we could do all these studies in parallel. We could do PET imaging for neuroinflammation. We could get ultrasound device. We could get a temporal interference, and we could do all these studies in parallel. But now, as in a domain where there is not as much money, you have to prioritize, and you have to say, okay, well, let's first do this, and then we do that. And so it's part the slowness of our understanding, but also in part, unfortunately, the slowness of the research funding.
Yes, and that's something we hope to address with Tinnitus Quest, where, also to manage expectations, we probably won't have like 100 million to distribute. So we're also looking at how can we get the most bang for our buck, let's say, with funding smaller studies. I didn't put that up on the screen. Let's hone in on some more specific types of treatments and your opinions on those. And then maybe we can also get later to, because you also have an important theory about the importance of combining different treatments, which also comes back to that, the importance of individualizing treatments, etc. But maybe first, let's just cover a few individual treatments and your opinion on those. And by the way, we're definitely going over time, so I hope you're okay with that.
Yeah, for me, it's fine.
Okay.
So why is clonazepam prescribed for tinnitus when it can worsen it in the long term? That's a very good question, and I prescribe clonazepam a lot. So I'm probably biased in it. The reason why we prescribe clonazepam is there is 3 reasons why we prescribe it. One is because many patients with tinnitus, 60 to 70%, have insomnia. And as I mentioned before, REM sleep and deep sleep are often disturbed in tinnitus patients. Now, clonazepam can improve REM sleep, so one of the 2 kinds of sleep. And therefore, it can be beneficial to help the influence, or let's say to stabilize the tinnitus, so there is less fluctuation. So there is also, it doesn't really change the loudness a lot, but to make it more stable, which often is associated with it making it a little bit more supportable. The second reason why is I also prescribe Deanxit. Deanxit is a very old drug. It exists for 50 years. It was originally an antidepressant medication, but there is a lot better medications on the market, so it's not used for that anymore. It's only used for tinnitus and depression. Now, so what Deanxit does is it reduces the focus on the tinnitus by blocking your dopamine D1 receptors. So what it means is, if you say, well, I have more than 60% of the time during the day, I'm really so focused on the tinnitus, then Deanxit is a good drug. If you say, well, I never focus on the tinnitus there, but it doesn't bother me, then it won't do anything, because you can't defocus from something you're already not focusing on. So only if you're very focused on the tinnitus, it's a good product. Now, the problem with that drug is that it can give tardive dyskinesias. And tardive dyskinesias is when you get twitches of your mouth or eyes. And this, of course, is very disfigurating, and it is very difficult to treat. Now, clonazepam can prevent it from happening. So I've never seen tardive dyskinesis after 20 years of prescribing clonazepam, and that is because the treatment is already given on beforehand as a preventive mechanism. Now, the third reason to prescribe it is because it activates GABA-A. And GABA-A is the brake of the chemical brake of your brain, whereas glutamate is the accelerator. And ultimately, if the brain goes in overdrive to generate tinnitus, then there is three mechanisms that are important. One is to press the brake, so to activate those GABA receptors, GABA-A receptors, and that's why people use clonazepam. The second one is to let the accelerator go, and there is only one drug that can do that, and that's not yet studied in tinnitus. It's perampanel, which is a new kind of antiepileptic, so we don't really know yet how well that would work. And a third mechanism is to shift back gears, go from fourth to third. So, and this is where the Deanxit comes in, and where other medications come in. So, of course, when we drive a car and we want to slow down, we do all three at the same time. And so the combination of using some drugs that could generate side effects, and it's not only Deanxit, quetiapine can do that, other drugs as well, is by already trying to prevent it from happening by giving a preventive. So there is at least three reasons why. Now, clonazepam and does usually not generate or worsen tinnitus. But what can happen if you stop all of a sudden with, so you have to very slowly taper it down. And I mean very slowly if you want to taper down the drugs, the clonazepam. Then if you stop it all at once, then you go in overdrive. Your brain goes in overdrive, which is again this fight and flight mode, and then your brake will not work and the tinnitus will become louder. So the risk is not in giving the clonazepam itself, because that would be extremely rare. It can, but it's extremely rare that it worsens it. But it can if you stop all of a sudden. So let's say there is more benefits to it than risks, and it's always the cost-benefit analysis, and that's why it's so commonly prescribed.
Okay. So, but that last bit is important, then don't stop it suddenly.
No, certainly not.
So also, you must see a lot of patients who ask questions about how do I sleep when I'm so bothered with my tinnitus at night. Is there anything specific that you recommend?
Yeah, so is there any sleep medication we recommend? Well, we just had a discussion about the clonazepam improving REM sleep. It does not tend to improve deep sleep, but trazodone 50 milligrams can improve N3 or deep sleep, as can melatonin, can sometimes improve N3 sleep. So it depends on, and this is why I love that so many people start wearing those smartwatches or the Oura rings, anything that gives more information about their sleep, and because that can help us say, okay, well, if you don't have enough REM sleep, then it makes more sense to use clonazepam. If you have not enough deep sleep, then it makes more sense to use trazodone. No, what's good about this is that in the setting of tinnitus, you never increase the dose, because that's a question that many people have. Then is, yeah, but is clonazepam not addictive? No, it is not addictive, but you can habituate to it. And what the difference is might be semantic, but it's very important, because just imagine alcohol addiction. Alcohol addiction means that if somebody feels sad and he has to drink, or she has to drink 1 or 2 glasses of wine or beer to feel better, then in time, those people need more and more and more and more glasses, and ultimately even drinking 2 bottles won't help anymore. That's what we call addiction. So it means that there is a constant increase in dose to get the same outcome. Habituation, however, means you don't change the dose, but you can't stop all of a sudden. You have to taper it down. So it is an important difference, because with addiction, you have escalating doses to get the same effect. But with tinnitus, even if you take clonazepam, you never increase the dose, and with trazodone, you do the same thing. So, and that is because we try to work on a specific mechanism, And it is important to understand that the brain for medication often uses what's called an inverted U-curve. So the inverted U-curve means there is an optimal dose. If you go below that dose, it won't work very well. But if you go over that dose, also it works less than in the optimal dose. So this is why it's important for people to understand that if, in contrast to a painkiller where people say, okay, well, I have pain. If one painkiller doesn't work, I'll take a second or a third, etc. For much of the medication that works on your brain, especially on your dopamine system, on your serotonin system, and on your noradrenaline system, this inverted Q-curve means that if you increase the dose, actually it will get worse because you're over the optimal top. And this is why it's very important to always use very low dose and never increase them, because you might push people over the top and then it will get worse.
So there's a lot of nuances there actually when prescribing these anti-anxiety medications.
Yes, indeed.
And maybe to move away from the medications for a moment, we've known about lidocaine, that it can help with tinnitus actually for quite a long time, I think, but it's something that you can't really use long term. I think side effects, I'm not really sure. But apparently it is being used occasionally. Are you aware of that? Is this really an available treatment option?
This is very interesting because it also mentions that it's especially for people who have reactive tinnitus.
Yeah.
So, which means that the lidocaine patches actually take away the modification of the somatosensory system on the auditory system. The problem is it doesn't work very long, and you can also habituate to it. So even though it's very interesting as for short-term benefit, in the long term, lidocaine is not an option to give long term, because you will develop habituation to the patches, and that might cause local pain in the long run. And the lidocaine doesn't really work very long. So it might be good to give transient relief, and this is what we know. People would give already in the 1970s. Were given intravenously xylocaine, and that worked very well for many people. The problem is that it's a little bit toxic on the heart, so you can't use it for a long term. And so the patches, even though they're interesting, might not be a long-term solution.
What's your opinion on neurofeedback? And maybe you can explain what that is. I think a lot of people don't actually know what that is.
Yeah. So neurofeedback is also a form of neuromodulation, but whereas with magnetic and electrical stimulation, you try to disrupt a network or to drive a network, neurofeedback is actually a learning mechanism. It's based on what we call operant conditioning, and operant conditioning is, for those of you who have a dog, know this very well. It just means that that you give a treat to the dog when the dog does something bad. So the dog learns by getting a positive reward, by getting a positive feedback. So this neurofeedback is the same, but instead of, so what you do is you put an EEG cap on, or you can do it in the fMRI machine or in the MEG machine, but most 95% or even more, 99% is done with an EEG cap. So we look at the EEG, we say, okay, this area is actually overactive and this area is not active enough. So whenever, and so we say that this is good and this is bad. It can be activity, but it can also be connectivity, so connections, and in the future, the whole tinnitus network. So then we say, whenever, because the brain is not, as I mentioned before, it's not a computer. It constantly changes. That when the brain accidentally gets good activity, that will be rewarded, and the reward can be that you have a little movie that continues playing and it stops, or it arrests, or it stutters a little bit when the activity is not good, and then ultimately the brain will try and say, okay, I want to see this movie. And so it will learn that this activity is associated with the movie going on, or it can be a piano sound that you hear. So whichever positive feedback that you get. And so ultimately, so you train the brain to start functioning well. Now, there have been studies with feedback. The problem, however, is that those studies do show that there can be some benefit on the distress, but less so on the loudness, which is a problem that we have with all the treatments up to now, except maybe cochlear implants, is that so it does seem to work, but there is no meta-analytic evidence yet. So, I mean, a meta-analysis is where you put all the studies that were done for one treatment, for example, neurofeedback, and then you see, okay, well, there have been 20 studies on neurofeedback. We will see how strong the effect is and whether it is better than, for example, placebo, or better than a waiting list, or better than whatever other control. And that has not yet been done for tinnitus. So there is no strong evidence yet from a scientific point of view that it is that it really works. On the other hand, you also have to see that it's not because it has not been proven that it does not work. And this is sometimes misunderstood, that they say there is no evidence, so you should not do it. No, there might be no evidence yet. It doesn't mean it doesn't work. It's just not been scientifically proven yet. And this is where therapies often are somewhat difficult to interpret, in the sense that you can also have another problem where they say, yes, it scientifically works, but it has a very small effect size. And when it says it scientifically works, it means statistically it cannot be attributed to chance. There is something that really benefits, but that tells you nothing about the effect size. The effect size, so statistics, what people often say, this P is smaller than 0.05. That means that you have 95% chance that there is something, that the treatment is really doing something, but that tells you nothing about how good or how bad it works. So you can have a treatment that is scientifically very good, but it reduces the tinnitus loudness from 9 to 8.8. Well, it might be scientifically correct. It might be not. It might work, but the effect size has clinically no value. So how do you then measure the benefit? That is by what's called the minimally clinically important difference. That's called MCID. And there's 4 ways of computing that. It doesn't matter that there's 4 ways, but that if we look at all the tests for tinnitus, it appears that you have to have more or less 15%, 10 to 15% reduction in loudness for tinnitus to have a clinically meaningful benefit. Now, if we look at all the meta-analyses that have been done, unfortunately, whether it is cognitive behavioral therapy, whether it is transcranial magnetic stimulation, whether it's transcranial electrical stimulation, whether it's acupuncture, if we look at all those meta-analyses, they usually give a benefit of about 10 points on the THI. That's one of the questionnaires. It goes from 0 to 100, which means you have about 10% improvement at the group level. That doesn't mean that an individual cannot be a lot better, or that some people have no benefit, but at the group level, you improve the suffering by about 10%, which is certainly not good enough. And this is why people like myself, but also others, have to continue looking for treatments that are not only statistically correct, meaning it's no coincidence that it's an improvement, but that have a lot bigger MCIDs, that have a lot bigger effect sizes.
Yeah, I think you mention cochlear implants as the exception here? Is that what you were saying?
Yeah. So remember that I was talking about the Bayesian brain, where if your brain makes a prediction that the sound should arrive, if it does not arrive, then you can develop tinnitus, because the brain thinks better safe than sorry. Now, hearing aids give a very good benefit in about 20% of the patients, gives a little bit of benefit in another 20%, and do nothing in 60% of the patients. However, cochlear implants are way better in treating tinnitus. But of course, cochlear implants were normally only provided to people who have bilateral hearing loss. So basically people who are completely deaf. or almost gone, or have no functional hearing anymore. But now there is also a group who have unilaterally functioning hearing and are deaf on the other side. And in that side, a cochlear implant can not only provide better hearing, but also reduce the tinnitus by more than 50% loudness suppression, and also way more suffering depression. So cochlear implants are actually the only exception where the benefit is more than this kind of magical barrier of 10%, and also the only one where you see, at least from a scientific point of view, that you can reduce the loudness dramatically.
The volume, actually, yeah. But I guess it gives hope that if there is one treatment that is able to do this, that other treatments should also be able to achieve this effect, because obviously a cochlear implant is not suitable for most people to get.
No, and I think what you just mentioned, Hazel, is extremely important. It just shows that we should not become defeatistic and say, well, we should just give up because we've been working on this for 20 years and we've only had very moderate success or very little success. We should give up. No, it shows, as Hazel just pointed out, that it has to be possible to take away the loudness, and that should also be our ambitious goal rather than just treating the suffering.
Absolutely. So, as you can imagine, we got many variations of this question. Many people are anxiously awaiting the release of this device as it's awaiting FDA approval. What are your thoughts, having no doubt read the studies?
Yes. To be honest, I have my view is I don't think very relevant. I would have to see the data first. I mean, longer, bigger studies first. I like the concept because Susan Shore has worked on it and on animals for most part of her career. So she knows this extremely well. So the way she designed it is really based on very thorough animal research. And so theoretically, it could work. The only fear I have is that just like the Neuromod, the tongue stimulation device, what we know from the Neuromod device, which is a variation, the Neuromod device stimulates the trigeminal nerve and with sound, and Susan Shore stimulates the C2 nerve with sound. There is other differences, of course. The timing is others, etc. Is that it might improve the suffering, but maybe not enough the loudness. I hope I'm wrong. However, the problem in the published study is that her outcome measure, which was actually guided by what the FDA suggested, was the minimum loudness, minimum masking level, or the loudness level. And this is the so-called more objective way of looking at tinnitus loudness. However, this does not correlate with the subjective perceived loudness. So now you have a measurement that can improve, but if it doesn't say anything about how loud you perceive it, then the question is, what does it mean for the patient? I mean, it's good for the scientist, and it's good if the FDA wants it, that's fine. But ultimately, the question is, are you going to have less loudness, or like the Neuromod device, is it predominantly, again, for improving in suffering? And so I would have to see the data first to see that it can reduce the loudness as well, but then on a measure that is relevant for patients, meaning subjectively, does it improve or not? And is it better than the MCID?
So I believe I heard from various sources that you are also working on a similar kind of bimodal stimulation device. Is that the case? And how is it similar or different?
Yes, so it is a bimodal stimulation device, and it is based on the pioneering work of Dr. Kilgard in Texas, where he showed in rats that if you pair vagal nerve stimulation with sound, that it can remove the tinnitus in all the animals. So we were lucky to know Dr. Kilgard. So we tested this in humans more than 10 years ago, and unfortunately, it was not as successful in humans as it was in rats. But while trying to understand and learning from Dr. Kilgard how it really works, I thought, well, maybe the model is wrong. And so what if the model that might work in animals is not the same as in humans? So the vagal nerve is a nerve that runs from the brain to your intestines to your heart, and it controls your vagal system, which is a rest, digest, and restore system. So if there is no danger in the environment, then you can rest, you can digest, and so then there is nothing important. And remember when I said, how does the brain with people with hearing loss decide whether or not to generate tinnitus is when your brain says this is important. So our idea is slightly different from Dr. Kilgard's in the sense that what we say is what if we present a tinnitus sound and simultaneously we activate the vagal nerve as to signal to the brain, look, it's not important. So that by reconditioning the brain that the sound is not important, our brain might habituate to it, and it would be like not feeling our clothes anymore. It should progressively be removed from the brain. So, and this is where I collaborated with Professor Sardijn from the TU Delft to create a stimulator that's very, very versatile, and that we now are hopefully can in the near future test in New Zealand. So the concept is different from even though it's also bimodal, it's different from Susan Shore's device, and it's different from Neuromod from a theoretical point of view. From a practical point of view, it's bimodal stimulation, but from a theoretical point of view, it's different. And so the goal is to tell the brain, look, the sound is not important, so you should not push it to consciousness anymore. Now, what was really interesting is that when Wouter Sardijn mentioned this, he said, yeah, we've built a device that treats tinnitus. And this is where but that was looked at from the engineering point of view. From the engineer, the problem was solved because the device was built. Whereas from a clinical point of view, we say, yeah, but we first have to test it. I mean, maybe my model is wrong, and then you've built a perfect device, but not for the right problem. So we still have to do the studies. I hope we can start with it in the next month or two, so that by halfway next year, we should have data on whether it will work or not.
Maybe to stay with the bimodal stimulation, because we mentioned Susan Shore's device, you briefly mentioned Neuromod. The device is called Lanier. We did get several questions also about Lanier, and I believe that's what this question on the screen is referring to, since that is the one that is FDA approved. I think you said it's merely a habituation device. Is that correct?
No. So Lanier works by pairing tongue stimulation, which activates your trigeminal nerve, and sound. So it's conceptually similar to Susan Shore's device. Unfortunately, it does well. The good news is it seems to improve the suffering somewhat more than most other treatments instead of by 10%, maybe by 15 to 17%. So there is some benefit. However, unfortunately, it does not seem to reduce the loudness. So it's good for people who say, well, it bothers a lot, but even though it's not very loud, it does bother me a lot, then it can be a very good device. But if you say, well, I'll only be happy if my tinnitus loudness is gone to zero, then it's not a good device for you. But it is not mere placebo. Well, most likely it's not mere placebo, but it tries to work on this kind of mechanism that I've discussed before. If it looks like a duck, if it flies like a duck, if it behaves like a duck, it's most likely going to be a duck. So it tries to change the brain's input on more than one sense in updating its verifications. Now, maybe one of the weaknesses might also be we have actually just submitted a paper for publication where we show with EEGs that when you have tinnitus, you also have abnormal activity in the somatosensory cortex, which could be good because that's where the bimodal stimulation works on, but also in the visual cortex and also in the vestibular cortex. But strangely enough, not in our olfactory or gustatory. So not in our taste areas and our smell areas in the brain, but our sight and touch areas and equilibrium areas in the brain are also functioning abnormally. So maybe instead of just using bimodal, we might have to go to trimodal or even four-modal, quadrimodal stimulation before we get a true reduction of the sound.
Would that mean stimulating various? No, so would it be combining sound stimulation with then stimulating 3 different nerves instead of just one?
Yes, or well, I'm more brain centric, so I would try to stimulate the cortex with transcranial stimulation, an electrical version of it. But you could also, for example, use a pillow that goes up and down for the vestibular system, and visual stimuli that go up and down with auditory stimuli simultaneously. So there is different variations you could develop in order to do that. And there was a Dutch scientist, but I've forgotten his name, who actually came up with the idea of this pillow that I mentioned to go up and down together with tinnitus. And we did some testing a couple of years ago together with him, and actually it seemed to give some benefit, but not enough to really go for full studying. But at that time, we did not understand this bimodal aspect very well. So now I think we should incorporate more of the senses. And considering that also the vagal nerve might be involved, we might actually go to more complex stimulation, because ultimately, once you've convinced the brain that it's not important and that it does not fly like a duck and quack like, then it should, in theory, not return. If the brain is convinced that the lack of auditory information is of no importance.
Well, I want to get also to the psychedelics, because I know that's a whole area that we still want to cover. But one more question maybe on brain stimulation or brain implants in this case. And I believe this is a company that you're also on the board of. Is that correct?
Yeah, I'm on the advisory board of the company. So Neurosoft is developing better tools to stimulate the brain with an implant. That being said, there has been no study yet to evaluate whether it is beneficial. Now, the implant is not specific for tinnitus. It is specific for cortex stimulation in the brain, which could be used for tinnitus, which could be used for pain, which could be used for depression or anxiety or any other pathology. But what is very nice about this company is that their first indication they want to look at is tinnitus, which is extremely rare. Most companies would go for pain or for something that is better studied. So it is a very soft implant that is ideally suited for putting an electrode on the cortex, so on the surface of the brain. But there has been no study yet. So it's a technical improvement. And remember what I mentioned earlier on, that once we have a new idea, we need new technology to help us test this idea. And so it fits in this line of research that gives us researchers better tools to study tinnitus, but it has not been done yet.
Let's get to the psychedelics. Is ketamine, and a lot of people for some reason are asking specifically about ketamine, so maybe you can address that one first.
Yeah. So ketamine intuitively makes sense to investigate it with tinnitus, because remember what I mentioned about plasticity, that if you look at plasticity from a single cell point of view, and even from a single synapse point of view, then we know that NMDA receptors are important for plasticity. So ketamine works on these NMDA receptors. So it makes sense that if you want to work on this neuroplasticity, that you try ketamine. Now, ketamine is a very dirty drug. I think it works on more than 27 different receptors, not just on these NMDA receptors. And it has remarkable effects for depression. So when we were still testing ketamine, when I injected it subcutaneously, within 2 minutes, the patients dissociate. What it means is that you're like Lucy in the sky with diamonds. The problem, however, was that the tinnitus became louder, but it didn't bother anymore. So the people were often describing it, yeah, it's even louder and it's sharper, but it doesn't bother me. So it became dissociated, and it's called a dissociative or something, from the sound perception. And the problem, however, is the dissociation doesn't last very long, 20 minutes maybe. And after 4 days, also the antidepressant or the anti-anxiety effect wears off. So you have to repeat it. So if you give it, then you can give it every 4 days for 3 months and then stop. And then you see that 1/3 of the patients are better, 1/3 a little bit, but not really. And 1/3 are actually not better at all. So there is a problem in that it addresses the suffering component, but not the loudness component. So
Right.
we went one step further, and we
Because that's
injected
exactly what the question here on screen is asking. Is it just to treat the anxiety? But sorry, go ahead.
Yeah. So we went one step further, and we said, okay, now we combine it with electrical stimulation of the brain under ketamine. But unfortunately, that gave no better results than just giving the stimulation in itself, or just giving the ketamine. We haven't published these data yet, but so that did not work. So we're actually, because of these results that unfortunately we haven't been able to publish yet, but because they're negative, we won't really pursue that effect. Now, so we won't really pursue ketamine anymore. Now, psychedelics are different from dissociatives. Psychedelics work predominantly on your serotonin 2A receptors, and they're products like magic mushrooms, in which you find psilocybin, their ayahuasca, their LSD. These are all called psychedelics, and actually MDMA or ecstasy also falls under the psychedelics, even though it has a very different mechanism of action. Now, these drugs work predominantly on stress-related problems. So the good thing about psychedelics is that I don't think some people who take ecstasy actually have transient improvement of their tinnitus, but we're interested in treating tinnitus, and we're actually going to do a study next year where we give MDMA, plus we will present the tinnitus sound, a little bit like what I mentioned about the vagus nerve stimulation and the auditory stimulation. So what we will do is we'll give psychedelics where the people then, with MDMA, you're in a kind of a bliss, you feel great, and then we will present the tinnitus sound so that it becomes dissociated from the negative connotation. And this we have learned from PTSD and post-traumatic stress disorder. If you give psychedelics and you do simultaneously, psychotherapy, so re-exposure therapy, so you ask the patients to relive their horrible trauma, then if you do that 3 times, and 85% of the patients have no criteria for a post-traumatic stress anymore. So it seems to be very, very effective for post-traumatic stress. So we thought, what if we consider the tinnitus as a kind of trauma, and we take away the negative connotation to it by presenting the sound simultaneously with the MDMA, just like they do in post-traumatic stress disorder. Then the tinnitus might initially be there, but it should not be perceived by the brain as being something negative, and therefore it might also be pushed away from memory, just like the trauma is pushed away from memory in the patients with PTSD. So hopefully that is another research topic that we are going to investigate. And as you have already learned from what I've been talking about, is we try to steal as many ideas from other disciplines in order to bring it to the tinnitus field, rather than trying to invent hot water again. Just see what seems to work in other disciplines and bring it to the tinnitus field.
Mm. You touched on it a bit already, and there is a question somewhere, but I can't find it right now. But what's the promise, in your view, of combining psychedelic therapies with other types of therapies?
Yes. Yeah. So I'm a great believer in what's called multimodal approach on tinnitus, which I've termed the war on tinnitus. And the concept is actually very simple. Just like in a war, you have the ground troops, the Navy, and the Air Force. They fight together. They're complementary. And we know this, that it can work for drugs from already a long time ago. And AIDS, when AIDS was discovered in the 80s, there was only one product. And people would live for 5 years, and then unfortunately they would die. Then the virologists were thinking, what if we use, it seems to work, but it doesn't seem to maintain. What if we use another complementary drug that works on this mechanism, but via a different approach? And by combining those very complementary approaches, people would live for 20 years. With it, adding a third drug for 40 years and adding a fourth drug, now people who are seropositive live as long as people who are seronegative. So basically, they're not cured, but it does not impact their survival rate or anymore. So the idea is that if we combine multiple treatments that all work somewhat, but insufficiently, that we can get better outcomes by attacking tinnitus like you would in a war from multiple fronts. And hopefully that will also help. And that's another strategy that can be attempted to really aggressively attack tinnitus.
Yeah, I found the question, put it up on the screen, but the person also asks for a bit more of a forward-looking prediction as to, when could we actually have something available in the market?
Yes. Well, that's a very difficult question, because sometimes let's assume that our study with presenting the tinnitus sound and the ecstasy gives benefit, let's say 60% benefit. Then we want to go further, and we would say, okay, well, let's add vagal nerve stimulation or add insula stimulation, so all complementary aspects. These have to be sequentially investigated for the reasons I mentioned earlier on. One is to have sufficient funds, and you also depend a little bit on what you found in a previous study. Now, even if you have a treatment that would work for, let's say, to put it very optimistic, for 80% of the patients, we can reduce 80% of the tinnitus loudness, then you still have the regulatory problems where the medical councils of the different countries have to accept that psychedelics will then be used as medication rather than illicit drugs. And as far as I know, Australia has already gone that far. So in Australia, psychiatrists can prescribe psilocybin and MDMA as medication. And this is very important because you want pure medical grade, high quality drugs, just like you would want in medications also to do the studies. And these tend to be very expensive right now and very difficult to get. So even if we would find, if we would find 80% benefit in 80% of the patients, that would convince the medical councils that, yes, we should be able to use it only in this indication for this set and in specialized tinnitus clinics. On the other hand, if you have only 50% benefit in 50% of the patients, then some medical regulations might say, no, it's not good enough for us to legalize it. And then, of course, you have to do more studies, again, in order to see what the benefit, how we can prove the benefit, maybe go into a more multimodal approach then to get results that those medical councils will accept as treatments.
Okay. I think there has been important progression, let's say, in the acceptance generally of psychedelics for treatments of various things, right? So there's some forward momentum, at least, on that. We haven't really touched meaningfully on hyperacusis, so I want to make sure we also address potential treatments for hyperacusis.
Yes. So what treatments do you recommend now for noise-induced hyperacusis? So when somebody comes with hyperacusis, we will try different approaches. So first of all, the ENT will look at the eardrum to see if there is a problem there. If there is a problem there, they will first put patches on the eardrum just to create some kind of mechanical barriers. So that's again, like, remember that in tinnitus we were talking about the bottom up and the top down approach. So there is always a bottom up approach that can be tested. And then we will also look at the top down approach by using medication that, again, tries to make the brain focus less on the sound, because the reason for hyperacusis is not exactly the same, but similar to the one of tinnitus. If the brain says, well, I want to extract, I don't hear very well, but I want to extract as much as possible from the environment. So then it changes the sensory gain of the cortex. And by changing the sensory gain of the cortex, it tries to extract as much as possible from the environment. Unfortunately, that causes hyperacusis. And then it depends on whether it is noxacusis, whether it causes pain or whether it just causes a discomfort by being too loud. So usually by the time we see the patients, they've already tried many things. They have already seen audiologists, they have already seen ENTs. So this is why, and audiologists and ENTs focus on the bottom up approach. That's why we tend to predominantly focus, of course, on the top down approach by using different kinds of medication. And they can involve calcium blockers, because calcium is a signal that something important is happening in the outside world. So when we use a calcium blocker, we try to tell the brain, look, don't worry too much about the brain. And this is also where CBT and TRT come in the sense that you try to convince the brain of the person with hyperacusis that actually it's just a normal physiological mechanism of the brain to try and extract as much information from the outside. It's not dangerous. It's just a problem. But often that might not be good enough, and then you can help this by adding some medication that works on the brake. Remember when I talked about this brake? The brake uses actually GABA. It has a receptor, dopamine, serotonin, noradrenaline, and opioids. So we then try to prescribe a cocktail that works on all these receptors, but extremely low doses, with the philosophy of this combined, this war philosophy on tinnitus to activate the brake. We also try to activate it by electrical stimulation of the brake and by disrupting the hyperconnectivity that we often see in the auditory cortex by using a noise-like stimulation. So it's, again, a multimodal approach, usually top-down, because the bottom-up treatments have already been done before they come and see us.
So we're gonna slowly wrap up, but I think I'll try to squeeze in a few more questions here. And I normally wouldn't ask about this, hypnosis or acupuncture, because it sounds like quackery to me. But for some reason, there's more than one person asking about this. So people want to know, what is your opinion?
So hypnosis, we have... there is no literature about hypnosis. That doesn't mean it doesn't work. It's just there is no evidence. The acupuncture, however, is very intriguing because it's predominantly used in Chinese medicine, and there's actually so many studies that there is meta-analysis on acupuncture that says that it does seem to have a benefit for tinnitus, and it improves tinnitus exactly the same as all the other treatments by about 10%. So for hypnosis, there is no data, or not enough data to give some advice, but acupuncture, even though we don't use it a lot, there does seem to be a scientific evidence that it might give some benefit to the same extent as cognitive behavioral therapy, or transcranial magnetic or transcranial electrical stimulation. So it's probably worthwhile. The problem with acupuncture is that there is lots of different acupuncture areas. So this just says targets. And what's interesting about this acupuncture spots is that they overlap with the areas that are targeted by dry needling or by electromagnetic stimulation. They overlap in about 95%. So it seems to be there seems to be a way in which we can try and explain it from a multimodal approach, just like you would do with tongue stimulation or with C2 stimulation of Susan Shore, or with what we will try, because it's known that acupuncture changes the balance between sympathetic and parasympathetic systems. So whereas for hypnosis, it's more difficult to explain what it does, for acupuncture, if we would reinterpret the imaging data, it might actually not be all that different from what we're doing. It just comes from a different tradition.
Yeah, interesting. This seems like a very one-off unique case, but it sounds intriguing to me. Someone who got treatment for psoriatic arthritis. I'm not even 100% sure what that is, but it seemed to have significantly reduced their tinnitus and hyperacusis. Can you explain that?
Yes. So this again points to the neuroinflammatory component, because psoriatic arthritis is where usually on the knees or elbows you have these red eczema areas around the elbows or the knees. So it's an autoimmune disease, which is associated with chronic inflammation, not neuroinflammation, but chronic inflammation. When treated by anti-inflammatory drugs, if they can get the right drugs that get to the blood-brain barrier, then it could also reduce the neuroinflammation associated with the tinnitus. So in that sense, it's not that surprising. However, not all patients who receive, and then of course there is multiple different kinds of psoriatic, multiple different kinds of anti-inflammatory drugs. I would be very keen to learn from this person which anti-inflammatory drugs were taken, but it fits perfectly well in the philosophy of, because it's unique cases like these that can give us some hints to further delve into the real mechanism of action of these drugs, and then say, well, considering that this specific drugs can modulate, let's say, TNF-alpha, interleukin 10 or interleukin 1 and 6 in the right way, if we can find an explanation for this one-off drug, then we might say, well, this is actually a drug that could be worthwhile to test in a larger group of tinnitus patients. And this is where we can learn a lot from tinnitus patients as well.
Yeah, from these one-off cases, it seems like an interesting lead. Yeah. Changing tax. Oh, wait, I put up the wrong question. Sorry. This one. Changing tax a little bit. Yeah, a lot of people also asking for advice about using sound therapy. I'm not really sure if it's something that you sort of tend to use in your clinic or believe in. And my question is there any evidence that it can do more than just mask your tinnitus or distract you from your tinnitus?
So, well, it doesn't really matter. I only believe data, so I'm not, for me, everything can work. I just need to show me the data, and if it works, it works. And if we don't understand why it works, then we have to try and figure out why it works. So we have done some studies on tinnitus, because initially we thought, well, if tinnitus is just filling in the missing information, which was a theory in the beginning that if you have a hearing loss at 6,000 hertz after a concert and the tinnitus pitch is matched at 6,000 hertz, it's just filling up the gap. So we thought we will, together with Professor Sardane, the same from the stimulator, because we already collaborate for 20 years, he developed for us a modification on the Apple players, and so we would adjust the sound to fill up the missing information in people with tinnitus. Now, theoretically, it made a lot of sense. Unfortunately, what happened is that when we were just filling up the gap, nothing really happened. And while we were actually overdoing it a little bit, so as to say to the brain, hey, look, there is lots of information coming in here, then the patients got a little bit worse. So we had to stop the study. And the reason is probably because when we looked at the EEGs, then what was different is that the brain in patients with tinnitus attaches salience, attaches behavioral relevance to the sound. Remember that if the brain says it's important, it will generate tinnitus. If it says the hearing loss is not important, it will not generate a tinnitus. Now, so that if you fill it up, then the problem is that the brain has already attached salience to that, so that it did not work. However, now going back to the multimodal approach, if you would do this simultaneously with psychedelics, then it might work because you can detach the salience then and you can fill up the sound. So theoretically it could work. So that's how we learn from every study that we do. Now, does sound therapy work? Well, as I mentioned, hearing aids can improve tinnitus in 20% of the patients. Now, what does not work is combining hearing aids with sound. And this is because not all treatments are complementary. So from a Bayesian perspective, if the brain predicts this sound should be there, it's going to try and find this sound in the environment. And so you apply hearing aids so that it might find the sound that it misses, and then says, okay, I've got the sound, I don't have to generate it, so the tinnitus goes down. But if you then at the same time mask the sound, then it can't find this missing information. So even though they're two sound therapies, from a Bayesian brain perspective, they should not be combined because they do exactly the opposite on the Bayesian brain mechanism. So that doesn't mean that the Bayesian brain mechanism is correct. But if the Bayesian brain mechanism is correct, then you would predict that these two combined cannot give any benefit. So and sound treatment from a Bayesian brain perspective does mask the brain to develop the tinnitus, and that could be beneficial, but probably not if you're still in a very stressed state. But if you're in a less stressed state and you say, okay, well, it bothers a little bit, but not, then it could be beneficial. The problem, however, is it only works if the tinnitus is not very loud, because if it is too loud, you have to create such a loud that you change one problem with another problem. So does it work? Based on our imaging studies, not really, except for masking, like what you said, Hazel.
Yeah. Is diet and tinnitus something you look at, and do you think there's like a significant influence there, or is it more like marginal? Maybe something triggers a little bit, but it's not really in the big picture. It doesn't matter that much.
No, I think you have already given the answer. There is no tinnitus-causing foods that have been discovered. There is no tinnitus-reducing foods that have been discovered. In general, like with everything, it is suggested that a Mediterranean food might be beneficial. And this is probably because a healthy food has an anti-inflammatory effect. So every food type that can worsen inflammation, like too much fats, too much, is probably not optimal. However, that being said, when we treat patients with tinnitus who also have what we call an exhausted brain, we do give them food supplements because what because what has been seen in the army is that if you push soldiers to the edge and then they have to do cognitive tests, that they're and you supply some food supplements like tyrosine at that moment, that is the building block of dopamine or adrenaline, etc., that they do their cognitive tests better. So the assumption then is that some supplements might actually create more cognitive resilience, and therefore you can tolerate the tinnitus better. That does not mean that the loudness will disappear, but so there is some mechanistic arguments that we should probably not be completely against it, but just study it and see could it do something, and if it does, and we have a hypothesis of how it works, and we know also how to verify whether it is just a placebo effect or whether there could be a true effect of it. But there is no, it's not because you're going to eat super healthy as from tomorrow that your tinnitus will go away.
Makes sense. So I know you've done with some degree of success, at least, deep brain stimulation surgery for tinnitus, but you're looking for less invasive methods of achieving the same, right? But some people still want to know, like, is this something that could ever be become widely available as a solution for tinnitus?
Maybe, and this is where companies like Neurosoft that we discussed earlier are also working on. The problem with DBS, however, is that, and brain implants, of which I've done a fair amount, is that it's a very small group. So it does not solve the tinnitus of many people. Now, some of the people whom I implanted, it did not work. And in some, it worked really, really well, where the tinnitus was almost gone or completely gone. So it just shows there is, again, like with cochlear implants, it could be an avenue. However, the invasiveness means that we, even though it might be beneficial, we should be able to find ways that can achieve the same results without the invasiveness. But we can learn a lot from those implants, like what's a good target, and for some people it might still work. The big problem, however, is that's not reimbursed, and those implants are extremely expensive. So we're talking now about 20 to 25,000 euros for an implant, and it's especially the battery that's so expensive. And then after 8 to 10 years, when the battery is empty, you might have to replace it, and then you're looking at the same costs for it. So that's why, from a society point of view, it's probably not feasible, but for the individual, for some people it could be very helpful. But then the question is, how can we tell on beforehand whether somebody would be a perfect candidate for it or not?
That's a good. That's a good question in general, right? How do we predict who will respond well to what treatment? But specifically, if you're going to be cutting open their skull, you might want to know that beforehand. Yeah. Is there any treatment existing or potential or upcoming that, like, we haven't talked about that you think is important to mention?
No, I think we've covered it. We went from psychology to neuromodulation to pharmacology to implants to multimodal approaches. So I think we've covered it pretty much.
It's a lot. Yeah, it's a lot. We didn't even get close to covering all the questions. I think we didn't get to half of them. So sorry for those who didn't get their question asked. I think we touched on almost everything, though, right? Tangentially, at least. I just want to pull this one up, just as nice to also be, thanked for your efforts. Yeah, I think hopefully people come away from this with a sense of hope that things are happening. There are new treatments on the horizon. We know there are certain things that work. It's just about finding things that work for everyone and getting them, and doing more testing and getting it out there. Are you? You said you're generally an optimistic person, so
Yeah.
you know you've said before that you always predict we'll get there in 5 years. But if you have to make a prediction now, like where do you think we'll be in 5 years?
Well, depending, of course, on the funding, that's critical. Because if there's more funds, more people will investigate tinnitus, more young people, and I do think that hopefully the solution will come from somebody young, somebody new in the field who has a very open mind and comes up with something brand new. Now, there's still more than enough ideas to keep us busy for a lot of years. But if there's more funding, then there will be more people who are also attracted to the field. It could dramatically change if we find an objective measure. This is probably the only topic we did not touch upon.
Yeah.
So we're doing we're going to do together with Professor Jae Sung from Korea, studies on with EEG to find objective measures. We were also involved in a project run by Rainwater Foundation to find other brain markers than on evoked potentials for tinnitus. So if we have an objective measure, then we might also start convincing companies to invest in it, because then they say, okay, now we've got an objective, just like you measure blood pressure and you can say, does the pill work or not? If we have an objective measure and we can show that it's really that you can trust this measure, then we will attract funding from the industry. So if that happens and we find an objective measure, then things could rapidly progress. If not, it might take a little bit longer, but yes, as an eternal optimist, maybe not in 5 years, but in 10 years' time, we might not have the solution for everybody, and we will not have the solution for everybody, but we should be able to treat a lot more people to give them a qualitatively good life, and be able to at least reduce the loudness in many people. Now, if we look at it in chronic pain, we see also dramatic improvements where initially people were happy with a pain reduction by about 50%. Now the goal is to reach 80% pain reduction in not only in 50% of the patients, but in 80% of the patients. So it's a slow improvement in the chronic pain field, but it's a dramatic improvement, because with a pain of 5, it's difficult. Well, you can live, but it's more difficult. With a painfulness of 3, apparently it seems to be doable. And so if we can achieve the same goals of having 80% of the people with tinnitus reduce it by 80% in 5 to 10 years, that should be a reasonable or an acceptable goal. Saying, well, within 10 years, we'll have 100% of patients having 100% success, that will not be the case.
Yeah, because of the diverse
Yes, indeed.
causes and manifestations of tinnitus. Makes sense. Yeah. Well, I think we're just going to have to do another one of these sessions, since there were so many more questions we didn't get to. But you stayed with us for almost 2 hours, so thank you so much for that, Dirk.
You're very welcome.
Thank you for sharing your time and wisdom. And hopefully it will inspire people to, join our what
Quest.
we call the quiet revolution. Yeah, indeed. And maybe then a very, very final question, like, what do you, we talk a lot in relation to Tinnitus Quest about the importance of involving patients in the solution, right? I mean, what can people do? What do you think is needed from the patient side?
Well, what we discussed earlier on, if somebody has a dramatic improvement with something, then just let it know, because it could be the start of a study that could help a lot more people. So my suggestion would be, I mean, if Tinnitus Quest is open to that, to have a place where people can say, look, I had terrible tinnitus and then I got this treatment. And I see that once in a while. People who say, look, I had terrible treatments. I was brought under anesthesia, and for 2 weeks I had 0 tinnitus. And then I ask, what was the product that you had? And then we try to mimic the product because, of course, you can't put people to anesthesia every 2 weeks. But then we try and look for products and see what receptors does it work on. Could we try? So everybody who has a profound benefit from something, whatever it may be, just let Tinnitus Quest know, because that can guide people like myself, but also other people, other researchers, to delve into it and hopefully find something that can benefit more people.
I think that's a great call to action. And yes, we do have a place where you can submit these experiences and ideas. If you go to tinnitusquest.com, I think it's on the homepage, there's a button, submit an idea. So an idea in this case being a potential lead for future research. So yes, please do submit any interesting experiences that you might have had that could give us new research ideas through the submit an idea button on tinnitusquest.com. And please also visit tinnitusquest.com for any future upcoming events. There's a separate menu item with events where you can see upcoming events. We still have an Ask Us Anything session coming up on October 26th, where you can meet all the board members involved in Tinnitus Quest, and we can discuss also issues beyond research, but go into funding, awareness raising, and all of those matters. So we hope to also see many of you there. We will now wrap this session up for today. I want to thank the audience so much for your active engagement. And final thank you also to you, Dirk.
You're very welcome. And I hope to see you all at the 26th, you said, of October.
Yeah, ask us anything.
Okay.
All right. Bye, everyone.
Bye, everyone.